Good evening, everyone. Welcome to today's session on its sciatica or neuropathy, how to tell the differences. My name is Dr. Razipur, and I will be moderating the discussion for tonight. And today's presentation, each of these speakers going to talk about 20 minutes for you guys. And at the end of the sessions, after the third speaker, we're going to have a question and answer sessions for you. Okay, our first speaker is Dr. Liam Harris. Dr. Liam Harris is a board-certified orthopedic surgeon, specialized in spine and general orthopedic surgery. Dr. Harris earned his medical degree from University of Southern California Keck School of Medicine, where he received the Dean's Distinction Scholarship in Research. He completed his orthopedic surgery residency at Harbor UCLA Medical Center in Torrance, and his spine surgery fellowship at NYU Langone Medical Center in New York City. Please join me in welcoming Dr. Harris.
Hello, thank you everybody for coming. Thank you for introducing me. As he was saying, so my name is Liam Harris. I grew up in the Bay Area. A little bit about myself. I grew up in the Bay Area from Oakland, California. I went to undergrad at UCLA, continued on to USC, then back to Harbor UCLA for my residency. So I'm been in Los Angeles for a long time now, back and forth from everywhere. I then did my fellowship out in New York, and then was in private practice up north, and then have recently relocated back to what feels like home, back down to the South Bay. So today for this talk, what I want to really go over is a little bit about what is generally considered known as sciatica, but in the medical community, we talk about something called lumbar radiculopathy. And I'll kind of get into the distinction and the differences and what it is, who experiences it, the pathophysiology, as well as how we manage it, and then other considerations. So just a little bit more about myself. I'm an orthopedics trained spine surgeon. In terms of, people often ask, what's the difference between orthopedic surgery for spine and neurosurgery for spine? And the answer is ultimately very, very little. These days, the overlap in my training consisted of both for several years. So it's more of very similar opinions about different problems. So first off, I want to talk about a little bit of what is lumbar radiculopathy and who encounters it. So lumbar radiculopathy and sciatica affects approximately 3 to 5% of adults in the United States at any given time. Lifetime prevalence is up to 40%. So almost half of individuals will experience it at some point in their lives. Peak onset is typically between 45 and 64, though it is something that can affect anyone from ages teenagers all the way up. In terms of what it means, it can be both mild in some patients, and then it can be extremely debilitating. Lumbar radiculopathy accounts for roughly $90 billion annually in the US in direct and indirect costs. People that are not able to go to work, not able to do the things that they're accustomed to, having to change their lifestyle. That affects everyone to some degree or another. And it's the leading cause of work-related disability and lost productivity in adults today in the United States today. So what is it? So traditionally, sciatica is what people consider this pain that radiates from the lumbar spine down the back of their leg, sometimes into their foot. Traditionally, it was considered pain primarily attributed to the sciatic nerve, which we'll get into in a little bit. But in the medical community, we lump it in with something called lumbar radiculopathy. And what lumbar radiculopathy is pain that goes from your back down into your legs caused by any of the nerve roots in your lower back. So that's, if you talk about the lumbar spine, there's typically 5 lumbar vertebrae as well as the sacral vertebrae. And any of those nerve roots, when irritated or compressed or with any kind of a mechanical trauma, can give pain that goes from the back down into the leg in different distributions. Sciatica traditionally referred to only pain in the lower lumbar spine. So that is L3 down to S1. But nowadays we generally consider it part of this bigger constellation of symptoms, which is any of that pain. So what is the pathophysiology of lumbar radiculopathy? What is it? What's it caused by? And there's actually can be several different causes of it. Really, if you think of the lumbar nerves in your spine, there's several different mechanisms which can cause irritation or firing of those nerves, which can then give you that back pain radiating down into your leg, down all the way into your foot sometimes. And we'll go over some of those here. First is mechanical compression. That's what most people think of when they think of sciatica or lumbar radiculopathy. It's an acute incident where something is pressing hard against that nerve root. Most people always hear of a herniated disc, or we talk about a slipped disc. That's what most people are thinking of. It is any kind of injury to the disc itself, which will then compress that nerve up against the spine or up against bone and give pain that radiates down that leg. So in this image here, you can see over particularly on the right, you can have this is your disc. You can have a disc herniation that will then press on that nerve, and then you may feel it in your back, but most people actually feel it going down into their leg, which is that pain that people really brings them into the doctor and can also be really debilitating. Those things can be from a disc herniation, which you've heard about, but it can also just be from an injury. It can be from a bad stretch on the nerve. It can be just from impingement, which we'll get into in a little bit later. But anything that presses on that nerve acutely, and you'll feel it in your back, and you'll often feel it going down in your legs. Other chronic conditions that can cause it, and we'll get into, are lumbar stenosis, degeneration or changes to the disc, as well as prolonged positional impingement, which is something that a lot of people have experienced, and then will come in to see me, which is anything where an inappropriate position can put too much pressure on that nerve for too long. That's the classic, is somebody who gets off a long plane ride, and then it causes this flare up of this pain that they're experiencing down into their leg. Other things that can cause it, which we often deal with, is an inflammatory cascade. So what that is not necessarily mechanical compression, but inflammation around the nerve root itself. And this is linked often to that disc herniation, which you talked about, which, as your body is trying to heal that disc herniation, it's sending all of these inflammatory cytokines to the area, which will then, while help heal the area, it will cause irritation of the nerve around it, which is very sensitive, which will also cause that pain to radiate down. The last one is one that I really like to talk about, particularly with my patients that come in, which is ischemia to the nerve. So changes to blood flow to the nerve can cause pain that radiates down from the back down into their legs. And what this is any time that as the space for the nerve gets smaller, which is something that happens as we all grow older. As you get older, your discs will lose height, which is part of aging. It happens to 100% of people. And as that happens, those nerves, as they come through that space, they're often very tolerant of that change. It happens over decades. So that space gets smaller and smaller. Most people, you don't even notice. It does quite well. But then what can happen is either an inopportune position, changes in position, or sometimes it just gets so tight that it will actually reach a tipping point and the blood flow to the nerve starts getting decreased. And so what then happens is that nerve will then, without blood flow, it will swell. That space, which was previously doing okay, will start to get bad. And then as the nerve swells in that tight space, it gets tight, and then people are starting to get symptoms. People come into my office and they're having this new pain. We get imaging, we discuss what's going on. And a reasonable question that I get asked often is, if this is age-related changes, why did it only start last week? Which is a very reasonable question. And it's typically part of this cascade. So as the space for that nerve gets smaller and smaller, it will do okay until it reaches a tipping point that it often is just too much, and the nerve will get impinged in that space. It will swell. Now it's swelling in a very tight space, and people are starting to experience symptoms. So get into it a little bit, but what is lumbar radiculopathy? How does it present? So what it is it's radiating pain, typically in a dermatomal distribution. So each of these nerves in your lumbar spine, which you can see here on the left, they go down and they innervate areas of your leg, muscles in your leg, as well as the skin. And so depending on which nerve is irritated, people will feel it in that distribution. So people will say, okay, if this is the problem here in my lower back, why do I feel it going down around the front of my leg and into like the inside of my heel? Well, that's because that nerve, which is getting pinched in the back, comes down and it controls the sensation, and it controls the muscles in your leg, particularly in that area. So if you bother it even up here, you'll feel that down in the inside of your leg. typically things that I advise patients to watch out for is it is often positional. It's often worse with weight bearing. As you stand up and start walking, it can cause compression on that nerve, and then the pain can sometimes get worse, which is not unusual. What's good that I advise people is that in terms of how to deal with this, things that are that I want people to watch out for, it's not so much the pain, which is obviously significant, but the red flag symptoms that we talked about are more weakness as well as loss of bowel and bladder function, which can occur with more serious conditions, but irritation of one nerve root typically will not. So things that I talk to my patients about when they come in, what I'd like to learn is how long has it been bothering them? Where is it hurting them? What is it impacting? Well, what are the things that it's changed the way you're living your life? On the physical exam, I'm looking for where they're feeling it, where the pain is. I want to make sure that there's strength in their legs. And then I get x-rays. I make sure to check that the spine is stable and things are looking good. As long as those are okay, we'll typically try to treat patients with conservative management, which we'll get into. But then if it's persistent or if it's been going on a long time, that's when we get an MRI. So some other things that I like to talk about in terms of what may mimic lumbar radiculopathy. Some things that are very important. And we'll talk about hip pathology. So any problems with the hip, many people actually feel that in their lower back as well. Piriformis syndrome, as well as knee pathology, hamstring injury, which we'll get into. So hip pathology, about 20% of hip-related pain presents as low back pain. So when patients come into my office, they'll often come in and very frequently they say, gosh, I'm having a lot of pain right here in my lower back. It's typically one-sided. And very often that can either be from the lumbar spine or from the nerve, but it can also often come from the hip. Not unusually, people will feel that radiating down into their butt or their hamstrings, sometimes into their groin as well. And so that's something that we always check for in clinic. And as I'm getting patients, trying to treat them primarily conservatively with physical therapy, stretching, it's something that we want to check to make sure that we're really treating the right problem. Other things to keep an eye out for hip problems, I typically advise people it's often worse with sitting as opposed to back problems, which are typically worse with standing. Not always, but in general. People often feel it go in the car. They really feel it going up and down stairs. Other problems which can mimic lumbar radiculopathy, piriformis syndrome. So this is the sciatic nerve, which you can see here. It's this big yellow structure that's coming out. Your piriformis muscle is a muscle that helps flex and externally rotate your hip. And what it can do is in some patients, it can actually compress the nerve as it exits out the back of the pelvis. And then people will feel that pain as it radiates down their back and into their legs. So oftentimes patients will come to me and they say, I've seen a doctor. What's going on? I'm having this pain that's really shooting down. My MRI looks completely normal. This is something that I like to exclude because it's often well treated with physical therapy and that we can often get it to completely resolve, but we want to make sure that we know what's going on first. So I'll touch on it a little bit, and I think my colleagues will get more into it, but we'll talk about the difference between radiculopathy or sciatica versus neuropathy. I like to typically impress that sciatica is often, it involves the spinal roots. It's often, but not always unilateral. So you just feel that on one side. And it has that typical dermatomal distribution. So you feel it going from your back down into your legs and down into your foot or wherever that nerve goes. Neuropathy is often related to the peripheral nerves. Frequently, it's bilaterally, and it'll often be a more general distribution. People will say their whole feet feel numb, or they'll get it at the bottom of their feet. In terms of what I do for my patients that come in with lumbar radiculopathy, typically most patients, which I mean to say about 95% of people can see significant relief with conservative management. So not everyone requires surgery, which is good. Normally things that we do is we'll get somebody into physical therapy. This is just a brief touching on it of all the things that they do, but focusing on core strengthening as well as paraspinal muscle strengthening, so the muscles in your back, and then really stretching out the lumbar spine and hips can often decrease the irritation of that nerve and improve the pain. Other things that we try, a short course of oral steroids is often something that can decrease the inflammation, the swelling of that nerve, and can really improve patient symptoms, as well as other typically non-narcotic medications, things like gabapentin, anti-inflammatories. And then when those don't work, sometimes there's a role for epidural steroid injections, which can be very, very effective in providing significant pain relief in people that are having a tough time. So this is something that we'll skip over. This is primarily for other doctors. But my patient philosophy, when patients come to my clinic, things that I want to do. Obviously, we want to understand what's going on, but I want them to understand their symptoms and what's happening. I'll often want to try, if we can, a conservative management first. I don't like jumping right to surgery. So that's often physical therapy, sometimes injections, acupuncture, anti-inflammatories, and only when all else fails will we often consider surgery. So things that I focus on in my practice, there have been a lot of changes in treatment of lumbar spine conditions, particularly with spine surgery. Nowadays, what I'd like to focus on, because everyone is, compared to 50 years ago, our population is a lot more active. These kind of things that we used to accept in the past when we'd say, okay, yes, this is bothering you. Unfortunately, this just means you can't continue to play golf. You can't play tennis. You can't play pickleball. That's not a reasonable plan in my eyes, and I think in most people's eyes today. So what we want to do when we're treating these conditions is we want to find a way to maintain your activity level, maintain your ability to do the things that you enjoy that bring you happiness, while often treating the pain. And so that's where a lot of this minimally invasive motion preservation surgery, which has grown so popular in the last few years, and it's something that I really believe in. I think if I can keep people moving and keep them doing the activities that they like, that really helps make everything else worth it. And if people come into my office and they say, oh, it only bothers me if I don't play tennis, I don't exercise, that's not a great solution in my eyes, because we got to keep you doing the things that you like. So I am just recently joined the Torrance Memorial Physician Network. I'm here. I have my offices here in Crenshaw and Hawthorne and Hermosa Beach. We've got my cards up front, so if any of you, we're taking new patients, so if anyone would like to come in at any point, I say just come on in. Thank you.
Thank you, Dr. Harris, for the great and informative presentations. Well, we continue with our second speaker, Dr. Issac Jenabi. Dr. Jenabi is a board certified in pain management and anesthesiology. He graduated from Johns Hopkins University with a Bachelor of Science in Molecular and Cellular Biology. He earned his medical doctorate from University of Pittsburgh School of Medicine. He completed his residency in anesthesiology and fellowship in interventional pain management at the University of California, Los Angeles. Please join me in welcoming Dr. Jenabi. The word.
Thank you very much for that great introduction. So there's going to be a lot of overlap between myself and Dr. Harris, but thankfully he did all the heavy lifting, so he made my job a lot easier. All right, so a little bit about me. You guys got the gist of it, but the one thing that I wanted to add is I was born and raised in the South Bay, born in Torrance Memorial Hospital, so this place is very important to me. So I'm very happy to be back. After I did my training at UCLA, I did practice pain management in Las Vegas for 4 years. I came back to Torrance Memorial in 2024. So Dr. Harris already touched quite a bit about this, but I want to highlight it again. So sciatica, again, we think about it as pain, burning, numbness, tingling pain that shoots down the buttock all the way down to the foot. And sciatica has been sort of this term that's been thrown around anytime back pain shoots down the leg, whether it's in the front, the back, the side. But like Dr. Harris had mentioned, there is a difference between something called radicular pain and something called a radiculopathy. So sciatica, when you just have pain shooting down the leg, it's called a radicular pain. But if you touch your leg, it feels numb. If that leg feels weak, it's called a radiculopathy. And again, all of these are caused by compression of the nerves of the spine as they travel down the leg. And so when we're thinking about how do the nerves of the spine go down the leg, we think of something called a dermatome. So basically what this is, it's a map of how the nerves of the spine, and especially in the lumbar area, go down the leg. So you can see here, when you look at the L5 and the S1 levels, that's the pain that goes down the side of the leg, down the buttock, all the way down to the foot. So most of the time, if someone has sciatic pain, it's along that dermatome. But again, any of the nerves of the spine can translate to pain to different parts of the leg. So again, Dr. Harris mentioned this, herniated discs and degenerative spondylosis. So those are the two big causes of sciatic pain. A herniated disc, most of the time, occurs at the L4, L5, and the L5S1 levels. That's the lower part of the lumbar spine. Why does that happen? Because that's where we do all of our movement. We do our bending, our extending, our twisting, all occurs at that level. Causes degeneration, can cause those discs to herniate. And then degenerative spondylosis, that's aging. As we get older, these little cushions between our bones, they get smaller and smaller and smaller. They degenerate. What can happen? You put a lot more pressure on those joints of the spine, they get inflamed, and it can cause compression of the nerve. So you see this term here, hypertrophied facet. That is when a joint gets inflamed, angry, it grows bigger, and it pinches those nerves, causes a pain that goes down the leg. Now, there are other causes of sciatic pain, but they're not as common as the two we just talked about. So diabetes, trauma to an actual nerve, infection, tumors, if anything metastasizes from a different part of your body. So if you have cancer, it can metastasize to the spine, put pressure in that nerve. And what does that feel like? Pain down your leg. So when we think about, again, the dermatome and how this pain travels down the leg, basically each of these areas feels like a different kind of pain. So if you're L1, the top of the lumbar spine, if that nerve's affected, it feels like a pain across your groin. Sometimes this can get confused with hip pain because it feels like pain in the exact same area. The L2, the L3, and the L4, they cross along the front of the leg. And so most often when people get this type of pain, it feels like pain with quite a bit of difficulty with getting up from a chair. And that's because you develop weakness in those muscles that are responsible for that. If you have compression at the L5 and the S1, again, you have that pain shooting down the side of the leg, the back of the buttock. At the L5 level, you might have weakness in lifting your foot up. And at the S1 level, you might have difficulty pushing your foot down. So if you're having difficulty pushing that gas pedal on the car, you may have an S1 radiculopathy. So who's at risk? So we talked about as you get older, you are at a higher risk of developing sciatica. Typically, if you're between the ages of 30 and 50, if you develop sciatic pain, it's probably from a disc herniation. But as you get older than 60, we start thinking spinal stenosis, narrowing around that spinal canal, causing compression going down that leg. If you're a very active person, if your job requires a lot of manual labor, a lot of that heavy lifting puts pressure on those discs, puts pressure on those joints, can cause degeneration, can cause sciatic pain. Obesity, the bigger you are, the more pressure on your spine. In fact, if you are obese, unfortunately, if you develop sciatic pain, you have a higher likelihood of going to the hospital. Tobacco use, if you're a smoker, there's a 33% increase in developing sciatic pain. Past smokers, thankfully, are no longer at risk. So if you're able to quit, that risk is reversible. Deconditioning, so inactivity. If you're not doing very much, those muscles that support the spine get weaker and weaker and weaker. Over time, can lead to more degeneration, compressed nerve, sciatic pain. Psychologically, you're not happy, if you're stressed, if you're anxious, if you're depressed, you're not going to be active. You're going to be deconditioned, muscles are going to get weaker, you're going to develop sciatic pain. So all of these are people who are at risk of developing this kind of pain. So before we get to diagnosis, we always want to identify something called the red flag signs. When do I need to go to a hospital? When is it scary? And the thing we worry about is something called cauda equina syndrome. That is severe compression of the spine. It could be from a severely herniated disc. It could be from a tumor. It could be from an infection. But what it presents as is profound numbness in the legs, weakness, sometimes lost control of your bowels and your bladder. We usually look for something called saddle anesthesia. That means numbness over the area of the body that touches the saddle of a horse. So the buttocks, the genitals, if you have profound numbness in that area, and if you have these symptoms, it can be a surgical emergency. So that would be a reason to go to the hospital. Other high-risk findings. If in addition to sciatic pain, you're having fevers, night sweats, difficulty sleeping, if you have a history of cancer, unexplained weight loss, those are all high-risk signs. Those are things that you should immediately contact your doctor about. But if you're not having that, when we see you in the office, what we're looking for is to try to localize where's your pain coming from. Do you have weakness? Do you have any numbness in the area? Where is it? Because that can help localize where the problem is. So what do we do when we need to find out what the problem is? We order imaging. And so the gold standard is an MRI. Why? Because it looks at the soft tissue, looks at the discs, looks at the nerves, And it's a very beautiful, beautiful picture right there. But if you can't, and the best thing about it, there's no radiation exposure. If you can't get an MRI, you can get a CT scan. It's not as great at looking at the discs and the nerves. It's great for looking at the joints, but if you can't get an MRI because you have a pacemaker that's not MRI compatible, that's the next best thing. Every once in a while, we do something called CT myelography. That's when we inject dye around the nerves of the spine to highlight them on a CT scan. This is useful for people who have quite a bit of surgical hardware in their back. So if you had a prior fusion, sometimes that can present as a ton of artifact on an MRI, and the CT myelogram can help us with that. So you can see here, this picture on the left, that's what an MRI looks like. The bottom is a normal CT scan, and you can see a CT myelography on the right side. You can actually see the spinal cord here. If we're still having trouble diagnosing the problem, we can order something called a conduction study. Basically, what we do is we use an electrical stimulus to stimulate the nerves that go down the leg, trying to look for any sort of nerve damage. Now, the beauty about this test is it can help distinguish between a radiculopathy and then what we'll talk about later, neuropathy. So if you have sciatic pain, what do? Most of the time, you just started having that pain. Most of the time, it will get better on its own within 3 months. It may not be a pleasant experience, but it will get better over time. But during that time, especially in the first week of symptoms, it's very, very important to avoid those pain-producing activities. So if you're doing a lot of heavy lifting at work, avoid that. Take a break from it. Do light work duties. Try to find a position that's comfortable for you, whether that's crouching, reclining, lying down in bed. Try to find that comfortable position. And when you can, when you're starting to feel better, start to incorporate some physical activity. Go for a walk. Being active can help reduce pain. Now, when you think of medications, the first line therapy when it comes to medications are actually anti-inflammatory medications. Ibuprofen, Aleve, for example, and there are the prescription ones, meloxicam, Celebrex, diclofenac. They are great anti-inflammatory pain medications, but they come with side effects, GI upset, ulcers, kidney damage. If you have kidney and liver issues, you should probably avoid anti-inflammatory medications. It can make things worse. So what do you do if you can't use that? You can use Tylenol. Tylenol is great. Even if you have kidney disease, you can use Tylenol. Even if you have liver disease, you can use Tylenol, provided that you limit the amount that you're taking. If you read a Tylenol bottle, it'll say you can take up to 4,000 milligrams in 24 hours. We really don't recommend that. Try to limit it to 3,000 milligrams, but if you have liver disease, take less than 2,000 milligrams. Steroids. So you can do something called a Medrol dose pack, which is pictured right there. It's a pulse dose of steroids. These guys are profoundly strong anti-inflammatory medications. It can really reduce that pain and help with inflammation, but again, it has side effects just like everything else. If you're a diabetic, it can increase your blood sugar. If you have osteoporosis, it can increase bone loss, make it worse. And it can, if you have high blood pressure, it can make the blood pressure go even higher. So all of these are helpful, but you just have to make sure that you watch out for these other things. Now, antidepressants and anti-seizure medications, duloxetine, gabapentin, pregabalin, these are very commonly prescribed medications. They are great for neuropathy. They're actually not great for radiculopathy or sciatic pain. Most of the time when they're prescribed off-label. The true first-line therapy is actually anti-inflammatory medications. Now, opioid medications. These are highly not recommended unless you're having severe, intractable pain, meaning nothing else is helping. The concern obviously is for dependency, addiction, the potential for overdose, death. When you use it, you don't want to take it for long periods of time. You try to limit it to 3 days up to 2 weeks. It does have a role, but again, it's not the first thing we jump to. When you start to feel better, usually after 2 weeks, that's when you should start incorporating some physical therapy, core strengthening, stretching. And then if that's not helping, you come see me and I do an epidural injection. And if nothing else helps, you can do surgery. So what are epidural injections? So that's when we use an X-ray to guide a needle to a nerve and inject steroid around that nerve to reduce inflammation and help with pain. These injections only help with pain. They're not getting rid of the disc herniation. They're not getting rid of the compression. It's not getting rid of the arthritis or the aging, but it can help with pain. Most of the time, we reserve these treatments for pain that's been prolonged after 6 weeks after trying conservative treatments because these injections have side effects, and we'll get into that in a little bit. The other population that we tend to target are people who have chronic pain. This is pain lasting longer than 3 months. If you're not a surgical candidate or you do not want to have surgery, an epidural injection can help with the pain. So like with most steroid injections, epidural shots, they have steroid. So it takes up to 14 days from full relief after an injection. They are same-day procedures. They can be done with or without sedation. It's preferable to do it without sedation. That's the safest way to do things. You're not having the risks of anesthesia added to the risks of the procedure. We do these in our office. If you come see me, we do epidural injections in the clinic. And we don't recommend more than 3 injections in the same area per year. Again, that has to do with steroid exposure. Like we talked about when we talked about steroid pills, there are side effects to medications, increased bone loss, worsening diabetes, but these injections can be helpful. Here are some examples of epidural injections. These are 3 different approaches. The first one here is called a transforaminal approach. That's when we target the specific nerve that's being compressed. The second approach is more of a generalized approach, trying to target multiple nerves. This is called a caudal epidural. This is useful for patients who have hardware in their back. So if you had a prior spinal fusion and we're really not able to access the transforaminal space, we can go through the tailbone and inject up. And this final one's called an interlaminar epidural injection, where we go right down the middle. Dr. Harris already talked about this. There are sciatica mimics. The one that I wanted to highlight, like he talked about, is piriformis muscular syndrome. You know, when we talked about a lumbar radiculopathy, we talked about spinal compression, but this is a sciatica pain that has no spinal compression, no compression of the nerves coming from the spine. It's actually hitting the sciatic nerve after it already leaves the spine. Most of the time, this does get better with physical therapy, and a big thing, the neurologic exam is normal. So there's no numbness and tingling. When you touch, there's no sensory changes, and there's no weakness. If physical therapy doesn't help, we can do an ultrasound-guided steroid injection into the muscle to, again, reduce that inflammation and hopefully help with pain. So now on to neuropathy. So again, when we talked about sciatic, we talked about pain caused by a compression of a nerve in the spine. Neuropathy is pain coming from damaged nerves of the peripheral nervous system. This is outside the brain, outside the spinal cord. It can affect one nerve, which is called a mononeuropathy, or multiple nerves, a polyneuropathy. And it tends to target the longest nerves in the body. That's why it starts in the feet and eventually progresses to the hands. What does it feel like? It feels like burning, numbness, and tingling. That's symmetrical, both hands, both feet. We call this the stocking glove distribution because it's like stockings and like gloves. Over time, it can cause weakness in the legs, in the feet. It can cause breakdown of the muscle. And it can cause balancing difficulties. If it gets very severe, it can start affecting blood pressure. It can cause erectile dysfunction, bladder dysfunction. It is a slow process. It does get worse over time if it's not treated. So what are the causes? The most common cause of neuropathy is diabetes. It accounts for 32 to 53% of cases. It affects 206 million people worldwide, and it's the 5th most common cause of disability globally. The second most common cause, unfortunately, is idiopathic. We don't know why. This occurs predominantly in people greater than 50 years old, where we can't find the reason why you're having neuropathy despite doing a full workup. Hypothyroidism can cause neuropathy. Toxic exposures. So if you drink alcohol, if you're undergoing chemotherapy for cancer treatments, medications, heavy metal exposures like to arsenic, to mercury, all of that can present as neuropathy. Nutritional deficiencies, B12, B1, B6, folate, copper, vitamin E. If you're deficient in that, it can cause neuropathy. There are autoimmune conditions that can cause neuropathy. So that's when the body attacks itself. You can be born with a hereditary disorder that causes neuropathy. Some infections can cause neuropathy, and even prolonged exposure to cold can cause neuropathy. So how do we diagnose this? So in the clinic, we're looking for loss of sensation. We're looking for walking difficulties, changes in your reflexes, atrophy, weakness. And how do we work this up? We order blood work. we're looking for glucose. So if you're diabetic and your glucoses are high, we'll order the blood work to see how high are they. Is this something that we can treat? We can check a thyroid hormone level. We can look for vitamin deficiencies, and then we can treat that underlying cause. Like we talked about earlier, there are conduction studies where we can use an electrical stimulus to test the integrity of a nerve and see if there's potential that it can differentiate between neuropathy and radiculopathy. You can do skin biopsies where they look at small fibers under the microscope, and you can do large nerve biopsies, although that's very much not recommended, and it's usually low yield because of how invasive it is. So how do we treat the problem? So if you have one of those reversible causes, then you treat that problem. So if you're drinking too much alcohol, cut the alcohol. If you're a diabetic, treat the glucoses. If you have vitamin deficiencies, vitamin supplementation can help. Otherwise, it becomes about treating the symptoms. So when we think of medications to help with neuropathy, that's when we start thinking about the antidepressants and the anti-seizure medications. So within the realm of the antidepressants, the FDA-approved medication is Cymbalta or duloxetine. It's very effective. Usually can get away with taking it once a day. Sometimes you can take it twice a day. With duloxetine, pain relief has been seen within the first week of treatment. However, if that doesn't happen, we still give a full 2 to 3 month treatment trial before discontinuing the medication. Like every other medication, it does come with side effects: nausea, dizziness, decreased appetite, constipation, sexual dysfunction, weight gain. The anti-seizure medications, I'm sure everyone's heard of gabapentin. That's the most common one, but it's not actually the FDA-approved one for neuropathy. It's actually pregabalin. They both act the same way, or at least very similarly. Pregabalin, or Lyrica, tends to be faster and more potent, but it's also more expensive. They do have a similar side effect profile: dizziness, sleepiness, weight gain. And if one medication doesn't help, a combination of medications might help, but you want to make sure you combine 2 different medications from 2 different classes. So if you're trying Cymbalta or duloxetine, you can combine it with pregabalin, but you can't mix within the class because there can be quite a bit of interactions between those 2 medications. There are topical medications that can help with neuropathy. Capsaicin is derived from chili peppers. They usually call this fighting fire with fire because capsaicin burns like crazy. Basically, over time, the exposure causes desensitization of the nerves and can help with pain. Lidocaine patches can be helpful. There is an over-the-counter supplement called alpha-lipoic acid, which has also been shown to be helpful for neuropathic pain. You can use a TENS unit. Basically, it's used to reduce pain transmission, but it's very, very short-lived. So if your pain is worse during a certain part of your day, use it during that small portion of the day. It can help during that time. Otherwise, it does fade away fairly quickly. Acupuncture has also been shown to be helpful for pain. Now, how it works is it releases the body's endorphins, so your own pain medications, and it can help with pain. If therapy is discontinued, usually after about 6 weeks, the therapeutic effects tend to wear off. So it is something you need to continue to do to get that pain relief. Physical therapy can be helpful if you're having balancing difficulties or issues with your strength. Or you can come see me and I can tell you about something called a spinal cord stimulator, which we'll get to in a second. What's not recommended, again, are opioid medications. There is no evidence of long-term effectiveness. And you have that risk of addiction, overdose, possibly death. So we tend to stay away from that medication. So spinal cord stimulator. So this is an implantable device that we place into the epidural space, the area where the nerves run, and we deliver electrical stimulation to the spinal cord to block pain signals from the legs from going to the brain. There's a large list of indications for spinal cord stimulation. You can see radiculopathy, sciatica pain is one of them, and then neuropathy as well. So what are the components of a spinal cord stimulator? There's an electrode, a battery, and a remote. The leads are the electrodes. That's what actually goes into the epidural space. The battery powers the device, and the remote controls the device. This procedure has 2 parts to it: a trial and an implantation phase. The trial is you try the device for 5 to 7 days. So what does that mean? So similar to an epidural injection, we use a needle to access the epidural space, but instead of injecting steroid, we put an electrode up there. And then those electrodes stick out of the skin. We tape a battery pack to your back and you try the device for 5 to 7 days. What we're looking for is at minimum 50% improvement in your pain and functionality at minimum. And if you get that, we take everything out and schedule you for an implant. That's where the battery is actually placed under the skin and the leads are placed under the skin. And this has been shown to have a 50% improvement in pain at 3 months compared to medications alone. Here are some examples of the batteries used for spinal cord stimulators. You can see that there are varying sizes and shapes. These bigger ones are non-rechargeable batteries, and then the smaller ones are rechargeable batteries. Now, when a non-rechargeable battery does die, it does need to be replaced surgically. It's a small surgery, but does need to be replaced surgically. Here are some pictures showing spinal cord stimulators. You can see the electrodes moving into place. Here is the battery pack that's already been implanted. Here are my references. Thank you very much. If you guys have any questions, please feel free to make an appointment and come see me.
Thank you. Thank you, Dr. Jenabi. That was great. Like Dr. Harris, it was great and informative presentations. Let's go with the last and third speaker, Dr. Reyes. Dr. Reyes is originally from Texas. Dr. Reyes graduated with a Bachelor of Science from St. Mary University. He completed a Master of Science from University of North Texas Health Science Center. He earned his degree in pediatric medicine from Western University of Health Science in Pomona, California, and completed residency training in pediatric surgery at Baylor Scott and White Memorial Medical Center in Temple, Texas. Please join me in welcoming Dr. Reyes to the podium. Thank you.
Good evening, everyone. Thank you for being here. So I'm going to cover peripheral neuropathy mostly. Peripheral neuropathy, or what's that tingling? So why is this important? I'm going to have some overlap with Dr. Jenabi there, but this affects approximately 1% of all adults worldwide, and up to 7% of those over the age of 50. There's multiple causes that can do this, and the symptoms can range from mild toe numbness to debilitating pain. The importance is that early recognition and treatment can prevent the future serious complications that I typically see in people with diabetes, such as ulcers and amputations. So what is peripheral neuropathy? The simplest definition, it's damage to the nerves outside the brain and the spinal cord. So that wiring that connects your brain to your hands and your feet. And you can think of it so that if your nerves are like electrical wires, neuropathies, and when the insulation wears off and the wire itself starts getting damaged. And that's what, so I'm going to use diabetes a lot because that's the #1 cause. And so that's what happens a lot, what happens in diabetes. The high levels of glucose over prolonged periods of time end up damaging that insulation of the nerve, and that's what causes this neuropathy to present itself. There's the nerves affected, they can be sensory, which is going to be your feeling. They can cause, issues with your motor nerves, which is movement, and then your autonomic nerves, which is going to be your automatic body functions like sweating and blood pressure. And so this is just an example here of, on the right, you can see where, that's kind of what an intact nerve cell would look like. And on the left, you will see what it looks like as a depiction of once that, that the sheath around or the insulation, you can think of has been damaged, worn down. So what's the #1 cause? And I'm going to touch on this again. Diabetes accounts for more, greater than 50% of all peripheral neuropathy cases in Western countries. Approximately 1 in 3 people are going to develop neuropathy that have diabetes. Type 1 and type 2 diabetes are risk factors. And so, like I said, high blood sugar is going to damage the nerves through the enzymatic process that I won't touch on today. And so this is the #1 cause that I see in my practice. This second would be alcohol use. This is typically decades of use, and then vitamin B12 deficiency. That's going to be common in older adults. Medications, that's another common cause, especially with chemotherapy drugs. That's an also common presentation in my practice. I see a lot of people that have been treated and now they're having neuropathy. Kidney disease, thyroid disorders, hypothyroidism. Less common but important causes going to be hereditary conditions, autoimmune diseases, infection, toxin exposure. And then really one of the key points is up to a quarter of these cases are going to not going to have an identifiable cause even after testing, which is what we refer to as just an idiopathic cause. Risk factors, greater than age greater than 50, diabetes, obesity, heavy alcohol use, a family history of neuropathy, medications, and how it starts. So this is this was mentioned earlier. So the stocking and glove pattern, because of the way it affects. So symptoms typically begin in the toes and the feet. It's the longest nerves that are going to be affected first. And there's a gradual creep upward as the neuropathy progresses and worsens. It starts toes, and then the feet, and the whole foot, up to the ankles, up to the entire lower leg. And then one of the defining hallmarks is that it's going to be symmetric or equal on both sides. Sensory, so the symptoms, what you might feel or not feel. Burning, tingling, pins and needle sensations. There's stabbing or the electric shock type of pain, increased sensitivity to touch. Then there's going to be the what we call negative symptoms, which is the absence of any of the sensation. So the numbness, what people really commonly say is that their legs feel heavy. So like feet feel dead or heavy. Difficulty in appreciating temperature changes, and then that develops into loss of balance and unsteadiness. For motor and autonomic symptoms, weakness in the toes and the feet, muscle wasting. So over time, some of this will actually sometimes present itself with, so people will develop hammer toes, and because of the weakness that ends up developing in the toes, and the difficulty walking and tripping, autonomic symptoms, the dry feet, digestive problems, and erectile dysfunction. So the issues that happen, or that where most people get, or where people get into trouble, are when people maybe have no symptoms, and so they don't know until they see or being seen in the office. This is when it gets dangerous because injuries go unnoticed, and that's what most people end up getting into trouble. So when people don't know that they can't, or they have neuropathy, they have if they have a certain level to it where they have what we call loss of protective sensation. So if you step on something, if you can't feel it. So if they step on a nail, they might not even feel it, and then that's where people get into trouble with infections, and then leading to the worse complications of needing surgery or anything, or losing a part of their limbs. And then on top of that, in diabetes, they have the complications of having poor circulation, which then impacts wound healing. And so then, foot ulcers develop, they can get infected and may eventually lead to amputation. And so in my practice with treating diabetic patients, foot ulcers and amputations are the most common complications. With neuropathy, you'll also have this loss of knowing where you are in space. So people are gonna have unsteady gaits, and so there's gonna be increased risk of fall, which then increases the risk of having a broken bone, injuring head injuries, and then if you're at risk of falling, then maybe that's you're at risk of losing your independence at that point, and need to be and so this is it gets dangerous as people get older. And so what to expect at an appointment would be detailed history, a comprehensive foot examination. So inspecting the skin, inspecting the pulses down to the feet, and assessing for any deformities. How do you test for neuropathy? Simple painless tests can usually identify nerve damage and predict the future risk of ulceration. I don't know, my pictures aren't there. Typically, one of the tests is a kind of like a fishing line. It's just a flexible piece of plastic. I usually have patients, feel it on their hand, because usually they have, they're still able to feel in their hands. And so, if they can feel it there, ask them to, then tell me where it is, and, where they can feel it on their feet and which, foot it is. And the worst case is usually, like, I haven't even started yet, because I usually have people, close their eyes and tell me when I'm doing, the test. And in the worst case, usually people are right away trying to, tell me they feel it, even though I haven't started. Vibration testing. So it is kind of a tuning fork. And so you just bang it on your hand and test it on your foot and see if you can actually feel the vibrations of that. Temperature sensation, reflexes, and then balance and gait assessment. And then advanced testing, we talked about this. If it's, diabetes, making sure knowing what your level of glucose control is. And then other than that, other testing, vitamin B12 level, thyroid function, kidney function, advanced testing if needed, nerve conduction studies, and skin biopsy or nerve biopsy. Treating the cause, again, really to hammer the whole point home, is that most important step is identifying and then addressing that underlying cause and treating the cause if it has a treatable cause. So if it's diabetes, making sure your blood sugar is under control, keeping glucose in the target range. B12 deficiency, then being supplemented with the vitamin B12, alcohol, reducing, stopping the intake of it, and medication related, seeing if that, medications can be altered. The important reality is that once you have neuropathy, complete reversal is uncommon, but the progression can often be slowed down or at least stopped. So we usually tell people is that once you have neuropathy, you have it. And the best way to making it any worse is to get what you can, get your sugars under control. Again, my practice, I see a lot of patients with diabetes. Managing the pain and symptoms. Topical treatments, lidocaine patches, and capsaicin cream. We just talked about those. And then, first line medications, gabapentin or pregabalin, duloxetine, and then the other medications as well. Again, another key point is the opioids are not recommended for neuropathy. And then for severe treatment-resistant pain, spinal cord stimulation. Lifestyle management. So this is the daily foot inspections. If you know you have neuropathy, then daily foot inspections are important, just because you're going to look for any warning signs, like calluses, any increasing redness in the area, blisters, because that means there's something going on and you're just not aware of it if you don't check. So, wearing properly fitting shoes, not going barefoot, checking the bath, checking the water temperature with your hands before you get into it. I see that a lot when, my practice, people just don't know how hot it is, or they fall asleep next to a heater and end up with, their feet blistered and burns. Specialized footwear if needed. Physical therapy if there's an issue with gait and balance. Healthy diet, whole foods, adequate vitamins, low glycemic loads, avoiding alcohol, and limiting, stopping or limiting smoking. The key takeaways and when to see your doctor. And so peripheral neuropathy is very common. It's especially in diabetes, it's gonna be, like we said, people are gonna feel it in their feet. That's usually typically where it starts, and that stocking glove distribution. Early detection and treatment of the underlying cause is critical for it to be under control. And then if you have neuropathy, then knowing, protecting your feet every day, inspecting, moisturizing, and wearing proper shoes. Your feet are your foundation, so you should take care of them. People don't know how limiting you are if once I tell people that you can't, walk on your foot because you have an ulcer or something, and it's really hard. It takes away a lot of your independence. And so I think it goes kind of, sometimes you forget about how much you need to have 2 feet to be able to get, around. Right. Thank you.
Thank you, Dr. Ray, for your great and informative presentation. Also, before we go to the Q&A sections, I'd like to thank you thank you all the 3 speakers for your excellent presentation. Each presentation was informative, engaging, and provided valuable insights. We appreciate the time, efforts, and expertise you shared with us today. And please join us and give us all 3 speakers a round of applause. And now in the QA section, they're going to, actually my colleagues, they're going to give us the paper and pen around, and you guys can write the question down and then be collected and give it to me, and I start reading it for our speakers, and they're going to respond to the questions. Oh, that's.
Yeah, that's what I think.
Okay, we'll start with the first question for Dr. Jenabi. I believe is a pain management. Do you need a doctor order or referral for peripheral treatment after PT, etc. have been tried?
For what treatment?
It says piriformis, right?
Piriformis.
Yes, piriformis trial.
Do we need a referral?
Yes, order or referral. Do we need the order?
Have to see me for piriformis.
Yeah.
Usually depends on the insurance, but you can call the office and you can find out. But yeah, no, we're happy to see everyone.
Okay, the second question is they want to know about the side effect of the B12. And
Normal dose for.
and also the normal dose for neuropathy for the B12 probably. That's what they ask. That goes for Dr. Harris probably or Dr.
So typically B12 is very well tolerated. Anecdotally, patients can sometimes say that it can make them feel jittery immediately after they take it, but those effects typically decline as if it's an oral pain or if you're taking it orally, people become more accustomed to it. It can only last typically for the first couple of days. And then in terms of the typical dose for neuropathy, I believe the oral dosage is typically around 500 milligrams, although because it is water soluble, it's very safe to take higher doses. So I frequently see people taking 1,000 milligrams a day, which is typically very well tolerated.
Okay, the next question is, says, will a spinal cord stimulate well work for a post-op cervical spine surgery? Yeah, spinal cord stimulator will work for a post-op cervical spine surgery. That's all.
So it depends. If you've had an anterior fusion, you can sometimes do spinal cord stimulation for cervical radiculopathies. Can you hear me? Okay. So it depends. If you've had an anterior cervical fusion, sometimes you can have a spinal cord stimulator placed for cervical radiculopathy. So it is possible. But in order to know for sure, you need to get an MRI of the back or the neck to see if there's actually space to put the electrodes.
Okay, the next question is, says, which doctor is the best to treat neuropathy, not from diabetes?
Biology.
Yeah, I think typically the first place to start is often with neurology. They deal with most of the conditions dealing with the small peripheral nerves. So when patients come into my clinic and their main concern is their peripheral neuropathy, it's often the first place they start. So I typically refer them to a good neurologist within their plan.
Okay, the next question is, says, I had a nerve conductor test for a pain in my leg calf area, but PA could not see nerve damage. Do I need our consultation with a neurologist to go over next step?
So I think it would be helpful. And again, remember we talked about with peripheral neuropathy, there are idiopathic causes of peripheral neuropathy, and it's very much possible to have normal conduction studies and still have peripheral neuropathy. Even with a radiculopathy, sometimes it takes time for nerve damage to actually present itself. So I think a consultation is a great idea.
Okay, this question, it says, is vertigo a symptom of these things or not associated? Vertigo.
Patients.
Typically vertigo can sometimes be related, but it's very atypical. So oftentimes it's there's many more common causes of vertigo. Sometimes central stenosis in the spinal cord can present with vertigo, but certainly peripheral neuropathy less so.
Okay, and this question, it says, how often should I visit a chiropractor to elevate lumbar pain? That's chiropractor questions.
So if you're going to go to a chiropractor, just, sometimes adjustments so chiropractic care can help with short-term pain relief. But over the long term, you have to be very careful with adjustments, especially of the cervical spine. Sometimes it can make things worse. But a lot of chiropractors, they'll incorporate acupuncture, they'll incorporate massage therapy, physical therapy. As long as they're doing those kinds of things, I think it's terrific.
Okay, this question says, can duloxetine be taken as needed?
So typically it's not as needed, just because sometimes it does take 2 to 3 months of taking it every single day to notice some pain relief from it. It's not often that you get that pain relief within a week. So it's more than as needed. It's going to be a daily medication.
Next question says, age limit on epidural. Cortisone can destroy cartilage. Yeah.
So not necessarily specifically epidurals, it's the steroid use that can lead to worsening degeneration over time. So whether that's in the knee, a joint, the back, wherever, if you're injecting steroid into a joint, it can cause thinning of the cartilage.
Okay, then this question says, if restless leg syndrome in procedure to sciatica or neuropathy? Yeah, a precursor to sciatica or neuropathy. Yeah, precursor.
So true restless leg syndrome, as we understand, is typically not. What I have found is that oftentimes, particularly with sciatica or lumbar radiculopathy, it can sometimes start with these feelings of just general discomfort, which can be very tough to articulate, understandably. And so people will come in and say, yes, like it's not necessarily true restless leg, but there's not a better way to describe it. It just feels like my leg doesn't feel normal. I constantly want to move it to find, it's often kind of in searching for a comfortable position. And that can be, yes.
And this question says, muscle cramps, especially in the calf area. I don't know what to refer to, but that's what it is. Muscle cramps, especially in the calf area. Yeah, probably that's what the asking says. That's the only one sentence.
Yeah. So, yeah, sciatica or lumbar radiculopathy can frequently present with cramping in the calf. Obviously, other things can cause that as well, particularly at night. Just generalized muscle cramps, electrolyte imbalances. But it is something that does sometimes present when based on irritation of the nerve roots in the back. People can say they're getting pain in their calf, can feel very, very tight. It can cramp up, and it often gets worse with walking.
And the next question says, I have taken ibuprofen since April and recently stopped that because of the dizziness. Is Tylenol the alternative or the other medications?
Why did they stop ibuprofen? Dizziness. So there are other anti-inflammatory medications within the same family. Typically I don't really see ibuprofen causing too much dizziness, but a small thing you can do is try a different anti-inflammatory. So instead of ibuprofen, try Aleve, and see if that dizziness still happens.
Okay. What if you have both sciatica and neuropathy? That was the first question. Can surgery cause neuropathy? That's the second question. I mean, just like a four. So you want to answer probably one of two.
So a person can absolutely have both. In terms of how it's best managed, you really want to try to look at them both to optimize both conditions as best you can. So as we talked about, whatever you can do to try to minimize the symptoms and manage the neuropathy, similar to the lumbar spine. If it's what can often happen, and I see it frequently, is that if someone's having significant lumbar radiculopathy and sciatic pain, oftentimes if that is relieved, people will start to notice more of that numbness, tingling, burning that may have been present but not so noticeable when they were experiencing this pain going down their leg.
And the question here on the laptop says, can you have both sciatica and neuropathy at the same time? I saw someone with Parkinson's disease. They said they have sciatica. What is the cause for them?
Yes, you can absolutely have both concurrently. There's as we talked about, there's so many different things that can cause that irritation of both the nerves peripherally, those very small nerves, as well as irritation upstream, the bigger nerves in your lumbar spine. So it's not unusual to have both.
Okay, and the next question here, it says, after 2 back surgeries, January 2025, and a hip replacement, January 2026, the skin on my thigh is extremely sensitive, and I get burning going from hip to knee, then across to my privates. Can neuropathy and sciatica cause this? Both my surgeons cannot answer this.
So yes, so there's several things that can cause that irritation of those nerves and across the front of the thigh. Classically, with the hip replacement, with an anterior hip replacement, irritation of one of the small nerves in the skin called the lateral femoral cutaneous nerve can often be retracted, and it has to be retracted during that anterior hip replacement. Some people will experience that persistent burning. It's actually got a name called neuralgia paresthetica. It can be very bothersome. It can continue to improve for up to a year. The other thing that can happen, which I see very frequently, is after a hip replacement, while people are recovering, their mechanics of gait change. You're moving with the walker, you're often standing slightly differently. And so irritation, some areas in the back can often get irritated because you're not compensating in the same way in which you were before surgery. So it's not unusual that people say, oh, I got my hip replaced or I had my knee fixed, and now something else cropped up. And it's often related to that recovery. And it can sometimes be very, very bothersome, and it can sometimes persist. And sometimes it actually needs significant treatment. But very often with enough time, things can improve. But it's not unusual, and it's something that I frequently work up in clinic.
Okay, and next question here says several spinal stenosis affected on nerves, severe spinal stenosis affected on nerves. And the following question says chronic piriformis, buttock pain relieved by gabapentin. Is that related to sciatica? The first question was severe spinal stenosis affect on nerves.
So yes, spinal stenosis is narrowing of the spinal canal or the neuroforamen, so where those nerves in the spine move and then exit. So that does cause compression. That will cause, it can cause numbness, tingling, weakness in the legs, as well as pain in the back that goes down into the legs as well.
And the second question was chronic piriformis, buttock pain relieved by gabapentin. Is that related to sciatica?
It can be. If, gabapentin it's been used for a long time, and it can, while it may not help everybody, sometimes it can improve the pain from the nerves. And so compression in the back can cause symptoms in their legs that can be improved with gabapentin. Yeah.
Okay, the next question online is, I have been told I have lumbar spinal stenosis and disc degeneration. I have low back pain. Main pain is felt under feet with tingling. I do not usually feel pain down the legs. Back pain and foot pain worse standing. PT and gabapentin partially help physical therapy. And gabapentin is partially help. You want me to read it again?
No, I think I would just comment that, lumbar stenosis will typically cause pain that radiates down, but sometimes people will just feel it in their feet or their calves. They can have back pain. They can have pain or numbness and tingling in their feet. It's part of that, it's something that we work up in clinic, and we like to evaluate, or I like to evaluate patients that come in with that. Sometimes there is reasonable treatments that can improve or eliminate those symptoms. But everyone's a little bit different. It's something I typically like to meet someone and review their imaging and assess, because something that I do try to impress on people is that just because someone may have spinal stenosis, it doesn't necessarily cause those symptoms. And so that's one of the reasons why I like to meet patients and really go over these things and examine them.
And that's one situation where a nerve conduction study can sometimes be helpful to differentiate. Is it a sciatica type pain or is it neuropathy?
Okay, this question says, how do blood clots affect sciatica and neuropathy treatment?
Well, deep vein thrombosis, or a clot in one of your veins that are in the main part of your leg, can cause venous stasis, which can cause tightness in the leg. It can also cause pain. It often gets better with treatment, but there are people they will experience consistent pain. It doesn't technically make the sciatica worse in that there's not new compression of the nerve, but it can be additive. That pain that people get from the clot sometimes can make things worse, and so their symptoms get worse. But it's not truly connected.
Okay. And this question says, how do I know that I'm getting better? or is the recovery masked by the medicine?
Well, if you feel like your symptoms are getting better, one of the things you can do is slowly start to come down on the medication, see if the symptoms change. So if you're taking gabapentin 3 times a day, try twice a day, see if there's a difference. If you're taking 300 milligrams, try 200 milligrams. This is one of those things where you can come in for an office visit and discuss like what is the next best way to come off of medication, see if you're improving.
Okay, and this question, it says, my sciatica is mainly in my right butt cheek. It's unbearable driving from LA to San Diego on a flight. Only affect me when I'm sitting. He said he's asking for help. He's probably asking for what does he has to do.
Yeah, I would, if you haven't, I would, speak with your primary doctor or come into clinic with us for an evaluation, and then we could probably be able to provide more answers.
Okay, and this question I think is asking, is it the high heels shoes? Probably is it related to the sciatica?
Well, technically, it's not something I counsel patients against. Everyone feels a little bit different. I have some patients that they say the high heels can definitely bother them. What I do typically recommend is it's not necessarily causing damage, particularly if the heels, if you notice worsening pain with high heels, then I would obviously say to try to wear them less or not at all. But in and of itself, that's not necessarily causing damage, and it's not something I would counsel against.
Let's have a couple of. Okay, here, let me read this carefully. Patient is a 1-year post C1, C2 panels removal with diffusion and laminectomy. Now fingers, what is tingling? Yeah, tingling probably. Tingling, remain tingling, also low back, hip pain, and MRI shows severe stenosis. The question, epidural, is it works?
I think that would really depend on how things look on imaging and would probably require a little bit deeper of a discussion. So I would advise that person to come on in.
Okay. Couple of questions. We have a problem with handwriting. Have nerve conductions test states neuropathy. I have none of the risk factors. Have SI fusion, multiple lumbar ablations, and SI fusion.
I don't know what is the question.
Yeah, what is the question? I don't know. So have nerve conduction test. Is that person is right? Wrote these questions here. No. Who is that?
Well, we could talk about this maybe in an evaluation, but sometimes conduction studies can also show radiculopathy on top of neuropathy. So that could explain part of it. And then remember, with neuropathy, there are idiopathic causes, meaning we don't know why you have it. A lot of people can just develop it, unfortunately, even when the workup is normal. So at that point, it really becomes about managing those symptoms.
Yeah, this is for Dr. Reyes. This is a slide number 9. Blood sugar control. And I don't know, this question is, what do you consider to be the
Target range
target range?
for blood sugar.
Probably that's what I was asking for, blood sugar. What do you consider to be a target range for the sugar?
Oh, so that's typically ideally, an A1C less than 7%. And that's, usually target range is hard because I don't really, keep read the logs of like every sugar check, but what I'm looking for is when an A1C report is at least less or 7% or less.
Whichever. Okay, this question actually says, I hurt my back 2.5 months ago in gardening, during gardening, moving soils in barrier for 2 days. The pain was in my back, but moved to the opposite leg, calf, foot. How long can I safely take naproxen? Yes.
So, unfortunately, with any anti-inflammatory medication, daily use for longer than a couple days to a couple of weeks can start to affect kidney function and liver function. People do take ibuprofen daily for years sometimes, but the trick is to always go to your yearly physicals and make sure that your primary care doctor is checking your kidney function and your liver enzymes. But typically, we don't recommend doing it for more than a week to 2 weeks at a time.
Okay, the last 2 questions. I think this question we can read, the other one, no. In the restroom and toilet, after sometimes when I get up, the leg is tingling and numbness sensations. After sometimes for standing, sometimes it wears away. It goes away. So it's asking put the questions mark. So it says probably wants to know what's the reasoning.
Yeah, I think it's not unusual that sitting, particularly on a very hard surface like a toilet seat, can cause some numbness and tingling into the legs, especially if you're sitting for a long time. Typically, what I often recommend is if it resolves quickly with a little bit of moving your legs around and getting comfortable again, then it's something that I would often just say try to manage with activity, try to limit your time sitting for long periods of time on a hard surface.
Okay, great. I think we missed only one question here, but we already read all the questions online, and that was great. Okay, we're closing the session. Thank you, everyone, for your participations, and thank you again for Dr. Harris, and Dr. Jenabi, and Dr. Reyes for their great presentations and sharing their expertise. And this concludes our session for tonight, and have a great day. I'll read it.